The topic I chose was something that can be applied clinically by each and every one of us. And I know from my experience as a postgraduate student at GDC Ahmedabad, where we used to see a lot of patients with pemphigus. And even the derm department would send those cases to oral pathology because we would be doing cytosmears in oral pathology over there. And so these are, many of these are conditions that are so prevalent in India as well. And so I thought, let me choose a topic that is of immediate clinical relevance, and also to add some notes on therapeutics, as many of you may be pursuing either biopsies for diagnosing these conditions or facilitating management of these patients. So we will keep all questions to the end of the presentation. And I believe I have 60 minutes, but I'm grateful to Dr. Saxena for providing me with some leeway in adding another 10, 12 minutes if I do err on the side of excess. But so here's the, okay, I got to cross another hoop over here. All right. So here's the outline of my presentation for today. I'll be briefly skimming over some principles of autoimmunity as related to oral autoimmune diseases. We'll be looking at some target antigens that play a role in the causation of these oral autoimmune diseases. And for those of you who are performing biopsies, I'll give you a pathologist's perspective on basics of biopsy in relation to some such conditions. And I really do not want to take cold to Newcastle, so I will only be rushing through some very basic clinical features, histopathology and immunofluorescence findings in selection of oral autoimmune disease. We are all pathologists, so I do not need to go into a lot of this. So the selected diseases I'll be discussing would be lichen planus, especially vis-a-vis lichenoid reactions, and briefly glance through chronic ulcerative stomatitis, mucous membrane pemphigoid, pemphigus vulgaris, and drug-induced pemphigus. And then we'll talk about lichen planus pemphigoides, and then I'll end my talk on this topic with current therapeutic options. So the pathogenesis of autoimmunity is not unlike many other diseases that we suffer, where the question always begs to be asked as to why is it that some people suffer from autoimmune diseases while others do not? People can live their entire lives without suffering from pemphigus or pemphigoid, while there are some people who get these diseases and it's with them lifelong. So this is akin to, I'm sure you're familiar as pathologists, the Knudson's two-hit hypothesis for cancer. So I'm just drawing parallels over here. In the Knudson's two-hit hypothesis for cancer, it says the first hit is always a genetic susceptibility. So one gene is already gone heterozygous and predisposes you to another gene becoming mutated, and then you get a homozygous cell which predisposes to neoplastic transformation. So the same thing happens in autoimmunity as well. Those people who are susceptible to these autoimmune diseases have an inherent genetic susceptibility. And so when they have the genetic susceptibility, there are cells in their body which are self-reactive lymphocytes, and they fail to recognize these altered antigens. But there are few and far in between before they suffer the clinical manifestations of the disease itself. So the second hit is going to be the environmental stimuli. So it's a chance, depending on the amount of tissue destruction, I would guess. It could be tissue destruction because of just trauma, because of an infection, because of innate inflammation of some sort. And Yeah, can I just request everybody to mute their microphones? Otherwise, it's kind of jarring in my ears over here. I'm not sure why. But anyway, so when we have this kind of an infection or tissue injury or innate inflammation, that's a second hit. And so when that happens, there's activation of antigen presenting cells. And so there's a heavy influx of these self-reactive lymphocytes into the tissue, mounting either an antibody-mediated immune response or an immune complex type of response, or in some autoimmune diseases, a T-cell mediated immune response. And so if you look at the table on the right of the screen, this is how we tend to classify human autoimmune diseases. It parallels the classification of hypersensitivity diseases. And so just going back to basic pathology, we know that hypersensitivity conditions are four types. Type 1 is acute or anaphylaxis. Thankfully, we don't have type 1 autoimmune diseases. That would be disastrous. So type 2 is antibody mediated, type 3 is immune complex mediated, and type 4 is what we call as delayed hypersensitivity. And in human autoimmune disease, we get type 4, which is along the same principles as delayed, and we call those as T-cell mediated diseases. So all these diseases that you see over here are systemic. You see, when they make these classifications, they really don't care much about the mouth. And so I just went ahead and added these conditions to the tables. So type 2 is antibody mediated. So the ones that happen in the mouth in using this mechanism of B-cell mediated production of immunoglobulins is going to be mucocutaneous conditions such as pemphigus, pemphigoid, chronic ulcerative stomatitis, linear IgA disease, paraneoplastic pemphigus, and epidermolysis bullosa acquisita. And so far as type 4 or the delayed or T-cell mediated disease, we have to put in lichen planus over there. It's mediated by CD8 cells. We do not know what the antigen is or what the mechanism is, but we know that the CD8 cells induce apoptosis of basal cells of the epithelium. And so all the action happens over here. So I'm sure you people are familiar with those two pictures on top to the left and right, and this cartoon that you see in the center at the bottom of the screen. So the action happens just above the basal layer in conditions like pemphigus, in chronic ulcerative stomatitis. So it happens at the layer of the hemidesmosomes and the lamina lucida of the basal lamina in diseases like pemphigoid. And the reason I'm saying diseases like pemphigoid is because you'll soon realize that mucous membrane pemphigoid, or cicatricial pemphigoid as we call it, is not a single disease, and we'll come to that. And then as we go deeper down to the type 7 collagen, the lamina densa, we get diseases like epidermolysis bullosa acquisita. And so here is a table that shows you the antigens that are involved in oral autoimmune mucositis. And so looking at the first one, pemphigus vulgaris, it's desmoglein 3. And so this is in the oral cavity. We do not express desmoglein 1 in the oral cavity. So antibodies to desmoglein 1 are typically seen on the skin. And it results in the condition that you're all very familiar with, that is pemphigus foliaceus. So we get blisters in pemphigus foliaceus in the more superficial aspects of the epithelium, while when desmoglein 3 is affected in the oral mucosa, we get acantholysis of cells immediately above the basal layer. That's something that we are familiar with, aren't we? So look at the number of antigens that are affected in mucous membrane pemphigoid. That's why I said it's not a single disease, but there are many, many different kinds of mucous membrane pemphigoid. Clinically, histopathologically, and using direct immunofluorescence, they make no difference. So even so far as management is concerned, there is no difference. So it's more a theoretical question. And however, the important thing to note is that when a person suffers from mucous membrane pemphigoid, at any given time, only one antigen is expressed over here. So you produce antibodies against only one of these antigens. So any of these antigens can be a cause for mucous membrane pemphigoid, but in any given person, in any given disease of mucous membrane pemphigoid in that person, antibodies are expressed against only one of these antigens. Now, why am I saying this? Because if you go down this list, you see paraneoplastic pemphigus, and to the right, once again, you see there are multiple antigens that evoke an antibody response. So in this condition, the antibodies are numerous, and they are against many antigens synchronously. So this is very unlike mucous membrane pemphigoid. So once again, to give you a bird's eye view of the difference, mucous membrane pemphigoid, many antigens can play a role, but at any given time, only one antigen is affected. While in paraneoplastic pemphigus, many antigens play a role, and at any given time, many antigens are affected synchronously. So bullous pemphigoid is a condition more common on the skin. Only 1/3 of patients with bullous pemphigoid get oral lesions. And same is the case with linear IgA bullous dermatosis. Although 70% of cases of linear IgA bullous dermatosis can present with oral lesions, but you never get oral lesions without skin involvement. So both bullous pemphigoid and linear IgA bullous dermatosis are more prevalent on the skin rather than being isolated to the oral cavity. So I'm not going to be discussing those. And epidermolysis bullosa acquisita is unlike its genetic counterpart, what we all are familiar as epidermolysis bullosa dystrophica, which is the commonest variant of epidermolysis bullosa. So this is an autoimmune disease, and it's against type 7 collagen. So it's much deeper. You know that type 7 collagen is also described as anchoring fibrils that come from the underlying connective tissue and hold the entire basement membrane to the underlying connective tissue. So it's a much deeper process. And so, you know, sometimes when you see antibodies at the basement membrane and you get bullous dermatosis, you want to know whether you're looking at epidermolysis bullosa acquisita or some kind of pemphigoid. You resort to what's known as a salt split skin technique. And so in pemphigoid, you're going to see the decoration of antibodies at the top portion of the split skin, while in epidermolysis bullosa acquisita, you're going to see the direct immunofluorescence decoration at the bottom portion of the split skin. And that's because of type 7 collagen. I will be showing you a case of chronic ulcerative stomatitis that I tried to manage, and then another case of lichen planus pemphigoides. So we will talk about those when we get to those slides. So biopsy essentials, perspective from a practicing pathologist who does direct immunofluorescence on a daily basis. So here's a patient, and obviously you can diagnose this as a mucous membrane pemphigoid. You can see the lesions are deep ulcers, and you can see they are yellow in color because of deposition of fibrin, and that happens only when the connective tissue is exposed. And so where am I going to do the biopsy? So here we have a Charlatan clamp, and the important thing is to not biopsy the area of ulceration or erosion, because that would be absolutely useless. So I need intact mucous membrane. I need the surface epithelium. I need the basement membrane, and I need deeper portions of the connective tissue. I need intact mucous membrane. And so the good idea would be to biopsy about half to 1 centimeter away from any affected tissue, possibly a mucous membrane that is apparently normal in appearance. And the depth should be at least 3 to 5 millimeters. And you'll see in some of the subsequent slides why the depth is so important over here. And so you take out one wedge, deep wedge of tissue, split it into two parts, put one part in neutral buffered formalin for routine hematoxylin and eosin staining, and put, excuse me, I'm going to take a sip of water over here. Thank you. Put the other part in Michel's transport medium. And so here are some of the things that we should keep note of when we are pursuing these biopsies and trying to diagnose these mucocutaneous conditions. And that is, at least over here in the US, many times dentists, they empirically put patients on steroids. And when nothing works, then they decide that they're going to send the patient for a biopsy or send the patient to an oral pathologist for diagnosis and management. And unfortunately, when the patient is on some treatment or on steroids, and if at that time you perform a biopsy, the findings are either going to be false negatives or the findings are going to be altered. So it's important to talk to your patients and first find out whether they have been treated currently for the condition. And if yes, biopsy by at least 2 weeks, a minimum of 2 weeks. So no steroids, no treatment, just go wing out on as the disease is, and steroids or any other treatment for at least 2 weeks. So the specimen that's put in Michel's transport medium, there are other names for it, Zeus medium. It's essentially a transport medium. It does proteins, and therefore it preserves the proteins as they are. So Michel's fixative is a combination of citrates and sulfates and ethyl malamide in just water. So stored in a refrigerator in your laboratory because it degrades pretty quickly. And also it's important that when you get the Michel's fixative with the tissue immediately. And so let's now quickly look at some of these oral autoimmune conditions. And I would like to first get lichen planus. And so I'm going to be using this position paper of the American Academy of Oral and Maxillofacial Pathology to support my claims. And so here, very, very briefly, this is to highlight the difference between lichen planus and oral lichenoid reactions. And, it's my understanding far more than we really should. And so here's why. Okay, so this is going to be, I'm trying to substantiate my claim. So the first case is 38 female with white striae. And to put things in perspective, the picture on the top right is the right side of the ventrum of the tongue. And the question is this like bottom? 54 female, white striae, is that lichen planus? And I'm not going to give you the answers now. You can start playing around in your heads. The third case is a sick buccal mucosa. Is this planus? The picture at the bottom, 33-year-old female, white striae with. And so the question is, are those white striae representative of lichen planus? And the last case over here, a 36-year-old male with white striae, is this lichen planus? So obviously not all of them are lichen planus, otherwise I wouldn't be showing them to you. And so in each of these cases, if you perform a biopsy, be one of a lichenoid mucositis, as you see in the picture on the left. You're going to get a hyperkeratosis, variable thickness of the epithelium, sawtooth-like epithelial cells, and there's deposition of fibrin in the superficial dermis. And you're going to see all those basal cells resulting in multiple colloid bodies or volume. And then in the connective tissue itself, you're going to see mononuclear cells, which are in most cases T lymphocytes. And the frozen section immunofluorescence that you do would demonstrate G, IgM, IgA, C3, and fibrin. And so all your slides would be negative except for fibrin, which presents itself as a shaggy deposit at the basement. So you combine your histopathology, the picture on the left, and the direct immunofluorescence findings, the picture on the right, and your diagnosis would be one of lichenoid mucositis. Can do. Now the clinician is in a dilemma. What is lichenoid mucositis and how correlation is a must? So what are the signs you look for to allow you to distinguish one lichenoid mucositis from the other, and lichenoid mucositis from lichen planus that you're going to ask of the patient? So the signs that you're going to look for are, how many lesions do you see? Is it a single lesion? Are there multiple lesions? If there are multiple lesions, how many different sites are affected? And what is the proximity of this lesion to metal restorations? Now, one other very important point to note is, I've always seen clinicians dental hygienists over here in the US do a much more thorough intraoral exam. And the dentists typically tend to miss porcelain fused to metal crowns. When I ask them for a clinical reaction, I say, Doc, do you know something? You got a porcelain fused to metal crown. And so more than likely, this isolated metal reaction to that porcelain fused to metal crown. And so because there's that veneer of porcelain, they failed to note that most of the crown is actually built or restored with a metal crown. So that's one ask are one of pruritus. That's one of the most important signs of cutaneous lichen planus, the 5 Ps: pruritus, polygonal, purple skin lesions, typically on the volar aspect of your hands, on the shin of the skin over the shin of your lower feet, and the smaller fingers, and they tend to be really itchy. And of course, you got to ask questions about the patient's hepatitis C status. Once again, I think we are hepatitis C with lichen planus. There seems to be a geographic predilection of persons from Southern Europe, especially Italians, and the Japanese hepatitis C with lichen planus. And then the other important question to ask is, has the patient suffered from myelosuppression, myelodysplasia, leukemia, lymphoproliferation transplant? And then we also have to ask the patients if there's been any temporal relation to medication use. Did they go recently to a doctor and mouth happen after they started taking those medications? And then any temporal relation to recent change in oral healthcare products. We see advertised a new brand of mouthwash, and the patient has started using these, and the oral lesions have happened after they have started, or recent habits. Someone is, coming close to their exams, and they have started chewing gum to keep their stress levels down. And so this is all because of we use cinnamon as a spice in so many of our dishes, and it does make the dishes so delicious, doesn't it? But the problem is when oil of chocolates and candies and chewing gums, the potency is at least 10 times more than the cinnamon that we use in our cooking. So that's the reason who are so used to all these spices could develop cinnamon reactions that present in the mouth as lichenoid mucositis. So going back to put in the signs to look for and the questions to ask into play. And so and I know that histologically and using direct immunofluorescence, they were all lichenoid mucositis. And so here is how I arrived at the diagnosis. So here was the first case, 38 female, white striae, and she did have other parts of the oral cavity presenting similar of Wickham. And there was no temporal relationship with any medication that she was taking, and all other questions were negative. And so a diagnosis. So you see, that leukoplakia is a diagnosis of exclusion. You rule out all other white lesions and you arrive at a diagnosis of leukoplakia in the same way that, even lichen planus is a diagnosis by exclusion. You have to rule out all other lichenoid reactions. And so the second case, 54 female, white striae, and you can clearly see that the white striae are localized to that metal crown. And there were no other lesions in the oral cavity. And so this So case 3, 62 male, white striae. He's on antihypertensives and is taking hydrochlorothiazide, and he did allude weeks after he started hydrochlorothiazide. And so this is what we call a stomatitis medicamentosa, and in particular, this is a lichenoid drug reaction. And then the bottom case, again, this was a presentation only in the left posterior buccal mucosa in relation to those old heavy amalgam restorations on those maxillary molar teeth. And so it was very localized. And so this was diagnosed as a lichenoid amalgam reaction. I do have biopsy findings on this, and I will be talking about that pretty soon. And here is the last case that I showed you. This situation, there were white striae in many parts of the oral cavity. And in the picture on top, you can see posterior buccal mucosa. There are some lesions on the left dorsum of the tongue over there, and extensive lesions that affect the actions, and trying to more in lesions that are well established and and will do lichenoid contact metal reaction against those huge amalgams in the molar teeth. And so here's the biopsy I got. And from top to bottom, you can see a hyperkeratosis, variable hyperplasia of the epithelium. I do not see any basal cells anywhere. Maybe one or two stragglers over there, but essentially the basal cells are all gone. And you can see lymphocytic destruction of the lower portions of the epithelium that's resulting in basal cell vasculopathy. And the important thing the inflammation is so dense that you get pockets of inflammation turning into germinal centers. I do not have a well-defined germinal center over here, but the more important thing I wanted to project in this case was this collections of lymphocytes around blood vessels. And you can see this one right at the bottom over there in the middle of the screen at the bottom, and heavy lymphocytic inflammation around the blood vessels, even in the fatty tissue of the buccal pad of fat. So here's why this depth of biopsy is so important. If you take a superficial biopsy and you fail to see this perivascular inflammation, you skew more on the side of lichen planus rather than a lichenoid mucositis. And so it's just the depth of the biopsy over here and looking at this perivascular infiltrate that supported my diagnosis of a lichenoid metal reaction. And of course, I had to put things in clinical perspective as well. So that's a lichenoid metal reaction. So how is a lichenoid drug reaction different? Not very. You get the same polymorphous inflammation, but lichenoid drug reactions tend to lack germinal center formation. They do not show perivascular inflammation as lichenoid metal reactions would. Contact cinnamon reactions would also show polymorphous inflammation. But another thing you're going to see in a lichenoid cinnamon or contact cinnamon reaction is you're going to see eosinophils crawling out of this polymorphous inflammation in the connective tissue into the epithelium. And contact cinnamon reactions may also show germinal center formation as well as perivascular inflammation. Of all these, I would say the most consequential is going to be a diagnosis of chronic graft versus host disease. So once again, very quickly, graft versus host disease happens in patients who have undergone bone marrow transplantation. for various bone marrow conditions, typically in leukemia and myelodysplasias. And so we try to match the bone marrow as close as possible from a donor. And so young age female patients, cord blood as opposed to bone marrow itself. It's in those situations where the histocompatibility would be more perfect, if there's a word like that, than otherwise. So patients would suffer from a response from these donated bone marrow elements, which would now propagate through the body and produce a lot of blistering and ulceration and exfoliation of the skin, what we call as acute graft versus host disease. And 100 days later, they would have manifestations in the oral cavity and on the skin that present more like lichenoid lesions, what we call as chronic graft versus host disease. And so histologically, what you would see in chronic graft versus host disease is, it's all dependent on the stage of the chronic GVHD. Earlier lesions would tend to show a lot more inflammation, and the basal cells that are undergoing degeneration would be surrounded by T lymphocytes. So you get a vacuolated basal cell with all these T lymphocytes in close proximity to these degenerating basal cells. We call that phenomenon as satellite cell necrosis, very characteristic of GVHD. And in later stages of graft versus host disease, the inflammation is less. And further down the progression, the inflammation reduces even more, and the connective tissue becomes more collagenous or more sclerosed. And what is important, we all know that chronic graft versus host disease is a pre-malignant condition. And so when you have biopsies of chronic graft versus host disease, and your doctor has given you that clinical information that this patient has undergone a bone marrow transplant, is that you look at the epithelium for features of dysplasia or even frank squamous carcinoma. So that's probably the most important take-home message for a lichenoid chronic graft versus host disease. It's the most consequential of all the lichenoid mucositis that we have spoken about so far. So give me a second. Thank you. So, I remember I told you before that we tend to diagnose lichen planus more than the disease actually is prevalent. And the reason is we are not cognizant of the fact that, many of our patients have significant health histories, and they have a laundry list of medications that they are taking. And so if you look at these medications, many of them are for commonly occurring conditions. The top one, antihypertensive agents, increased blood pressure is so common and prevalent. Sulfonylureas for type 2 diabetes mellitus, again, a very common condition. Levothyroxine for thyroid deficiencies, sulfasalazine, allopurinol. Gout is so prevalent among the Indian population. Non-steroidal anti-inflammatories, everybody's popping an ibuprofen for this ache and that ache. Carbamazepine, anticonvulsants, and high cholesterol statins. So all of these are commonly used medications, and they are known to cause lichenoid reactions in the mouth. And so it's very, very important to look at the health history and medication history and make that temporal connection and not jump to a conclusion that your patient is suffering from lichen planus. Why is this important? Because number one, of course, if your patient is suffering from reticular lichen planus, you do not need to treat reticular lichen planus. It's totally asymptomatic. But if your patient is suffering from a lichenoid reaction because of any of these medications, either altering the medication or taking off the medication, if not required, would treat the condition. So it plays a very significant role in management of these conditions. You do not have to put your patients on steroids. So please keep all these medications and the health history in mind, and do not jump to a diagnosis of lichen planus. So here's this interesting case. It was managed by a periodontist, and since the patient still suffered from symptoms, the patient was then sent to the dental school, where I had a chance to meet this patient, and a second biopsy was taken. And at the dental hospital, we have more facilities, so an immunofluorescence study was also done. So 55 female, she was refractory to management of what was suspected to be lichen planus. And so there are two different pictures over here. And at the one on the left, you can see on the right mandibular posterior gingiva, they look fairly erythematous with fine white lines. And so the suspicion was, could this be erosive lichen planus? And then the picture on the right, you can see white striae with areas of erosion. And then, of course, there are heavy metallic restorations, or maybe that's just a deep cavity over there. But anyway, the periodontist was treating this empirically as lichen planus, and obviously the patient was refractory to treatment. And so the biopsy was taken, and histologically it did present as a lichenoid mucositis, but it was the immunofluorescence that nailed the diagnosis. So fibrin presented just like one would expect in a lichenoid mucositis, as a shaggy deposit at the basement membrane. But what really took the cake was the immunoglobulin G, and it decorated the nuclei of the immediate suprabasal cells. And so you know what the diagnosis is, it's right over there. So antibodies to stratified squamous epithelium nuclei in the lower third of the epithelium with this kind of a direct immunofluorescence presentation is characteristic for chronic ulcerative stomatitis. So here's another condition that presents clinically and histopathologically as a lichenoid mucositis, but direct immunofluorescence, especially IgG, clearly shows there's a difference in the staining pattern, and therefore you establish the diagnosis as chronic ulcerative stomatitis. So moving on, mucous membrane pemphigoid. Once again, it's not a single disease. There are many different types of mucous membrane pemphigoid. Many antigens can elicit an antibody response in genetically susceptible individuals, but at any given disease, it's only one antigen that's responsible for the condition. In mucous membrane pemphigoid, the separation or disjunction occurs at the region of the hemidesmosomes and the lamina lucida. So the entire epithelium sloughs off, leaving behind these raw, exposed connective tissue areas that then get capped by fibrins. So lesions of mucous membrane pemphigoid look a little more yellow in color, unlike pemphigus. And so that's one important clinical differentiating factor between mucous membrane pemphigoid and pemphigus that textbooks will not tell you. And so mucous membrane pemphigoid, that's somebody's child over there. Mucous membrane pemphigoid typically happens in older individuals, those in their 60s and 70s, and somehow it's skewed more towards females than males. And so here are the antigens, as I said. So subtyping will require an immunoblotter ELISA. So is that really necessary? I think that's only for research purposes, and it's of only theoretical importance, because in any given antigen eliciting an antibody response in mucous membrane pemphigoid, the clinical features, the histopathology, and the direct immunofluorescence findings will be identical, and there's no difference in the way you manage these cases. So mucous membrane pemphigoid is more a condition, as the word itself says, of the mucous membranes. And so in about 1/3 of cases, you can get facial blistering with severe scarring, what we call as the Brunston-Perry variant of mucous membrane pemphigoid. And so if for some obscure reason, it seems to affect the rest of the body. And so we are familiar with the histopathological findings. You get a subbasal split exposing the connective tissue, and direct immunofluorescence findings would show immunoglobulin G at the basement membrane, as you see in this picture, as well as C3 at the basement membrane. These are very characteristic findings in mucous membrane pemphigoid. And in rare cases, in the mouth, you might see an intact blister, as you see in this clinical picture. And so most significant problem with mucous membrane pemphigoid is not the mouth, but the eyes. And so as you see in this picture over here, this patient is developing. So what happens in the eye is the inflammation results in scarring of the lacrimal duct. And so the eye becomes totally dry. There's a keratoconjunctivitis and there's scar formation. And one of the scars looks like a web, as you see over here, that it's connecting the palpebral to the bulbar conjunctiva. And so we call this scar a symblepharon. And so you know that scars always undergo contracture. It's a basic principle of pathology to bring a large wound margins together by scar contracture. So as the scars contract, they tend to draw in the eyelashes. And so that's what we call as entropion. And these eyelashes, when they turn in towards the orbit itself, it tends to scratch the bulbar conjunctiva, resulting in further ulceration and keratinization, what we call as trichiasis. So what the eye surgeons would do is they would just go ahead and start plucking out the eyelashes, as you see over here. And so this is to prevent the trichiasis, but the very act of epilation of the eyelashes results in further trauma. And so there's progression of trauma in the eye. And you see what's happening over here is that the depth of the fornix of the eye is reducing over a period of months. And so as there's more and more of scar deposition and the depth of the vestibular fornix in the eye reduces, the patients can barely open their eyes. And so even though the optic nerve is functioning, the retina is excellent, the eyeball is functioning, the patient undergoes blindness just because of obstruction of the palpebral fissures. And so it's very important to prevent this from happening. And so it's very critical for us as oral pathologists that if we see a patient with oral mucous membrane pemphigoid, we refer these patients to an ophthalmologist to rule out any ocular disease. And so pemphigus vulgaris is another well-studied oral autoimmune condition. If you compare these lesions of pemphigus vulgaris to those of pemphigoid that I just showed you, in the mouth, the lesions tend to appear more red, unlike those of mucous membrane pemphigoid, where the lesions are fibrin covered and tend to look more creamy yellow in color. And the reason that lesions in pemphigus are more red in color is because the connective tissue is not exposed. And we get this single layer of basal cells that are continuous and still present in the mouth. So the target antigens in pemphigus vulgaris in the mouth is desmoglein 3. In the okay. So the antigens in the skin are desmoglein 3 and desmoglein 1. When desmoglein 1 is affected, the lesions tend to be more superficial, and in the skin, it results in the condition known as pemphigus foliaceus. Okay, so here's the histology of a case of pemphigus vulgaris. And even at this very low magnification, you can see the basal cells are very much intact, and there's disjunction happening immediate suprabasally. And here's a higher power, and you can see the basal cells are intact, and you can see acantholysis happening to the immediate suprabasal cells. And when this disjunction results in individual free floating cells, we call these cells as Zhang cells. Now, when these individual cells are free floating, they lose their desmosomal connections to their neighboring cells. So all the toxins and byproducts of cellular metabolism are not passed on to the neighboring cell and out into the connective tissue. So they tend to accumulate within the cell itself, and the cell becomes ballooned out. And after a while, the cell just explodes and releases its fluid content into the space over here, and that's what results in the vesicles in pemphigus vulgaris. So here's the direct immunofluorescence finding in patients with pemphigus vulgaris, and you can see the cytoplasmic membranes of the suprabasal cells are decorated with immunoglobulin G and with C3. And so in pemphigus, we get circulating antibodies as well. So 80 to 90% of cases of pemphigus would have circulating antibodies. And so you can also use indirect immunofluorescence to diagnose the case of pemphigus vulgaris. Now, you do get circulating antibodies in mucous membrane pemphigoid as well. But unlike pemphigus, only about 5 to 15% of cases of mucous membrane pemphigoid would show the presence of circulating antibodies. So we do not typically use indirect immunofluorescence in the diagnosis of mucous membrane pemphigoid. So very quickly, I also want to talk about drug-related pemphigus-like lesions because, once again, this is very consequential in managing cases of pemphigus. And so once again, if you look at these drugs, they're fairly common. Some are antibiotics, and some are antihypertensives, some are painkillers, some are anti-inflammatories, very, very common medications. And so to try to explain how medications can cause pemphigus-like lesions, we just divide them into those that are thiols, as in cephalosporin and penicillinamine, and penicillin, that's benzyl penicillin, as thiols, and all the other drugs as non-thiols. And here's the proposed mechanisms. The thiol drugs may interfere with critical enzymes that keep the epithelial cells together. And so when they interfere with those enzymes, it results in cleavage of the desmosomes. Or they could bind to desmoglein 1 or 3, creating an entirely new antigen and thereby evoking an antibody response. Or the thiol drugs may bind with these antigens and interfere with the normal function. So when normal function is obstructed, it can result in acantholysis. Now, unlike how thiol drugs can play a role in pemphigus, non-thiol drugs, there are 2 mechanisms proposed. One is some of these non-thiol drugs may undergo hydrolytic breakdown to form thiols. So we call these as masked thiols. And then they could produce pemphigus in either of these top 3 mechanisms. Or more likely that non-thiol drugs can induce acantholysis by inducing an immune response, as in true pemphigus vulgaris. So whether it's the thiol mechanism or the non-thiol mechanism, clinical features and routine H&E histology would be identical to pemphigus vulgaris. And in non-thiol drug-induced pemphigus, even the direct immunofluorescence is going to resemble idiopathic pemphigus vulgaris. So you see what I'm getting at is, like lichenoid drug reactions, even pemphigus could be caused by drugs, and it's very important to recognize the medical history of these patients and look at their medications that they are taking. So these are commonly used medications, and not jump to a diagnosis of idiopathic pemphigus vulgaris. Because if this is the reason, if the drugs are the reason, all you got to do is withdraw these drugs, withdraw these medications, or change the medications, and you have your case of pemphigus. And you know that pemphigus cases are protracted. Oral lesions are first to show, last to go. It's a disease that causes more morbidity than pemphigoid, requires systemic steroids for treatment. It's hard to treat. And so if you can make this connection between medications and the pemphigus-like lesions, you do not have to do all of that. And all you have to do is to withdraw the medication or change the medication, and you have treated your patient. So once again, clinical correlation is a must. Look at the medical history, look at the medications that they're taking, and ask yourself a question. Could these lesions be caused by something out of that medical history, out of that list of drugs that they're taking? And so that makes the situation so much more easier for you as well as for your patients. So let's look at the next case. 50-year-old female, lichen planus like areas, but the surgeon said the epithelium is dehiscing. So what's going on? And so here's a clinical picture the clinician sent me. There were vague areas of white patches with maybe some streaks of white lines. And so here's the histology of the case that I got. You can see the epithelium is significantly atrophic with hyperkeratosis. And you can see there are a lot of lymphocytes going into the epithelium. There's destruction of basal cells. You can see colloid bodies and civeate bodies so easily. The basement membrane is more flattened out, except in this one pit ridge. And you can see a mononuclear infiltrate in the connective tissue. And so, typically, so these are frozen section H&Es. So when we get a specimen in Michel solution, before you run antibody stains for direct immunofluorescence, the first slide that you cut should always be stained with just plain old rapid H&E. And the reason is you first want to figure out whether, so when you have tissue coming in as a frozen section in Michel's, you cannot see the tissue. It's kind of transparent, hard to visualize. And so the first section that you stain with the rapid H&E, a twofold importance over here. One is to see if there's any epithelium at all, because you're talking about blistering disease, and it's possible that your epithelium has been lost entirely. So you need to confirm whether there's epithelium. And if you do not see any epithelium, okay, please mute your microphone. Okay, so the important thing is, if there is no epithelium present in the first section, you do not waste hundreds of dollars of money in running the 5 different antibodies. So it also may be a problem with orientation of the specimen. So you can try twisting the specimen by 90 degrees and making another cut and stain with rapid H&E. And once again, trying to see if there's any epithelium at all, because if there's no epithelium, then more than likely you're not going to run those 5 antibodies. So here's what I saw in this section, the specimen from this patient. And so the picture on the top left, so these are from different portions of the same tissue. And so it's a pretty lengthy piece of biopsy and pretty deep as well. And so the picture on the top left, you see variable hyperplasia of the epithelium, and you can see some lichenoid, sawtooth-like epithelial rete ridges. I do not see basal cells over here, and patchy mild deposits of mononuclear cells in the connective tissue. And interestingly, on the picture on the right at the bottom, I'm also seeing a subbasal clefting process. So this is what I saw in the direct immunofluorescence, heavy deposition of fibrin that goes along with the lichenoid mucositis. But on the other four antibodies, I was surprised to see at the basement membrane C3, and this insert over here is from another area, just to show that how intense the C3 was at the basement membrane all through the biopsy specimen. And the picture on the bottom left is a low power of immunoglobulin G. And so the red box is highlighted on the picture on the right. And you can see how immunoglobulin G decorates the basement membrane. And so the diagnosis was lichen planus pemphigoides. And there are several interesting papers in OOO as well as other journals of dermatology on this condition, oral lichen planus pemphigoides, that explains this disease in detail. But briefly, you tend to have patients with lichen planus-like lesions, as you see in this picture on the top right. And after many months to many years, it evolves into a pemphigoid-like condition where you can see this explorer has been put between the epithelium and the connective tissue, showing what we sometimes refer to as a Nikolsky sign, where there's separation of epithelium. And the picture on the bottom right, the histology shows atrophy of the epithelium with atrophy of the basement membrane, absence of rete ridges, isolated colloid bodies, and inflammation in the most superficial parts of the connective tissue, what we call as a lichenoid mucositis. And the picture on the bottom left over here, that's letter D, a subbasal separation, which is pemphigoid-like. And so here's another paper by Lynn Solomon, and you can see these clinical lesions. They look like erosive lichen planus, and on a biopsy, you see the subbasal separation with sawtooth-like epithelial rete ridges. Now, a word of caution over here, erosive lichen planus can show subbasal separation. So you see when the basal cells undergo vacuolation, the hemidesmosomal apparatus is no longer present. And so even in cases of erosive lichen planus, you can see the epithelium separating from the underlying connective tissue. And that's what causes the lesions to be erosive. But in erosive lichen planus, you are not going to see this kind of a histology of C3 and IgG at the basement membrane. Okay, so lichen planus pemphigoides belongs to the superfamily of pemphigoid. And so remember I said that mucous membrane pemphigoid is not one disease. Several antigens are involved. And so lichen planus pemphigoides belongs to that superfamily of pemphigoid. However, patients tend to be much younger. Mucous membrane pemphigoid typically affects patients in their 60s and 70s, while lichen planus pemphigoides is a condition of patients younger by at least 20 or 30 years. It arises in a setting of lichen planus. So the first diagnosis is always that of lichen planus, and many months or several years later, a repeat biopsy would show you pemphigoid-like histology and direct immunofluorescence finding as well. So a subset of cases of lichen planus pemphigoides are associated with use of medications. Once again, we come back to the health history. And in most cases that have been reported, it's simvastatin that's been the culprit of lichen planus pemphigoides. So what is the antigen in lichen planus pemphigoides? It's very limited to this NC16A domain of BP180. BP180 is also known as type 17 collagen. It plays a very important role in mucous membrane pemphigoid. But in lichen planus pemphigoides, it's this NC168 domain of BP180 that acts as the antigen. So there's several reports out there trying to explain how lichen planus evolves into lichen planus pemphigoides. And so the concept of epitope spreading was proposed by this group from Italy. And so very simply put, when you have inflammation, as you have plentiful in lichen planus, there's significant amount of tissue damage. This tissue damage results in exposure of a sequestered antigen. In case of lichen planus pemphigoid, it's this N618 domain of BP180. And so when this antigen is exposed, it elicits a response from B lymphocytes, resulting in a secondary autoimmune disease, what we call as lichen planus pemphigoides. And so that's a concept of epitope spreading that has been proposed to explain these cases of LP evolving into LPP. So I'll now move to management essentials. I'm going to rush through this since the latter part of my topic does involve therapeutic management of these cases. So here are some very important things to keep in mind. Patient education and compliance is very, very important in managing autoimmune diseases. You must understand that when a person suffers from an autoimmune disease, it's their own body's immune system that's fighting self-antigens. And so you can never cure these patients. A person who has rheumatoid arthritis is never going to get their rheumatoid arthritis 100% cured. We can only push the symptoms of rheumatoid arthritis or any given autoimmune disease back as much as possible. So it's more symptomatic treatment, alleviation of discomfort with morbidity associated with these diseases. It's not a 100% cure. Your patients should understand that. Response is always delayed. Your patients should not believe that your treatment is magic and that they're going to feel better overnight. Responses using the same medication can vary from one patient to another. And since we cannot 100% cure these autoimmune diseases, maintenance therapy is absolutely essential. And in many cases, it's lifelong. And in many patients, your treatment may require sequential change of medications to see what is most effective for that particular person. So we are talking about, idiosyncrasy. One person is so different from another and they respond variably to medication. So you got to figure out, and your patient must understand these essentials when you begin treating their immune disease. So first I'll talk very briefly about management of these conditions and then talk about some medications in particular. Bottom line, lichen planus, if it's the reticular type, it requires no treatment. Reticular lichen planus is asymptomatic. Do not provide any treatment for reticular lichen planus. Other erosive kinds of lichen planus, typically you have a whole range of medications. Steroids are preferred. We'll go through some medications eventually. There are other immunomodulators and immunosuppressive agents like azathioprine, methotrexate, mycophenolate, thalidomide. Be very careful prescribing thalidomide to pregnant patients. It causes significant limb deficiencies known as phocomelia in the patient. And most of these immunosuppressives and immunomodulators are very, very toxic to the fetus. There are other biological agents. Rituximab is a favorite of mine. Doxycycline, dapsone, hydrochloroquine. And then there are other things like, this is just haldi, curcuminoids, aloe vera, phototherapy, that's puva. And so here's what happens when you provide steroids in patients with reticular lichen planus. It just results in thrush. And so it makes the patient feel far worse than they were. And so when you give these patients antifungal medications, it just brings things back to normal. So bottom line is asymptomatic reticular lichen planus, do not treat them. Management of CUS, corticosteroid therapy is less effective than in lichen planus. So the mode to treat CUS is using Plaquenil. I should not have put that trade name, maybe different in the Indian pharmacopoeia. So we're talking about hydroxychloroquine, 200 milligrams twice, 4 times a day, depends on extent and severity till the lesions heal. Treatment of CUS is, very favorable because 70% of those patients, as per this study in O, undergo remission following cessation of treatment. Once again, chloroquine is very toxic, and you got to monitor your patients for all these side effects, especially the cardiac features with neuromyopathy with extension of the QT interval, agranulocytosis, bone marrow suppression, aplastic anemia. So it's important that if you're going to be providing your patients with hydroxychloroquine or quinine, you subject the patient to complete blood tests every few weeks. So management of mucous membrane pemphigoid, if other mucous membranes are not affected, we categorize that as a low risk condition, and we put the patients on topical steroids. And so I don't do this. I prefer actually putting the patients on tetracycline with niacinamide. That's my prescription in the middle in bold and underlined over there. And so the concept behind using tetracycline in the management of mucous membrane pemphigoid is, we don't give tetracycline to kids. And excuse me. The reason is tetracycline chelates with any metallic ion. So in growing teeth, it chelates with calcium and it stains the teeth yellow. It chelates with calcium in the bone as well, but you don't see the bone. So the idea behind using tetracycline in treatment of mucous membrane pemphigoid is that tetracycline, these are non-bacterial properties of tetracycline, and that is tetracycline chelates with zinc in the connective tissue. And so when zinc is no longer available as free zinc in the connective tissue, matrix metalloproteinases cannot be activated. So matrix metalloproteinases are collagen degrading enzymes, and their activation depends on the presence of zinc. So that's why they are known as zinc matrix metalloproteinases. So when you provide tetracycline, the tetracycline removes zinc, and so matrix metalloproteinases remain inactive, and destruction of collagen is prevented, and therefore disjunction at the level of the basal lamina is prevented. And that's one mechanism for management of mucous membrane pemphigoid. And obviously it's less toxic than steroids, so that I always start with something less destructive. So tetracycline, niacinamide, 250, you can go up to 500 milligrams each, 3 times a day. And patients who take niacinamide sometimes complain of a vascular flush. And so if you give them 350 mg of aspirin, that vascular flush that you see on the face is prevented. And so if this doesn't help, my next line of treatment would be a calcineurin inhibitor called tacrolimus. And I've gone on in several patients who have not responded to tetracycline niacinamide. And of course, this treatment with tetracycline and niacinamide should go on for at least a month to 2 months before you move to something as I would prefer, that's a tacrolimus. This is a calcineurin inhibitor. We'll talk about this a little later. And I try to avoid steroids as much as possible in management of MMP. But if these fail, then I would go on to some very strong topical corticosteroids. And always keep in mind that steroid-induced candidal infection it should always be borne in mind, and antifungals may be needed. And so it's only in those patients that are resistant to treatment with any of these medications, you need to put them on systemic steroids. And you know all the side effects of systemic steroids with myelosuppression. And so you have to, constantly measure their TPMT levels to make sure that their bone marrow is not being suppressed. And so that's how you manage patients with MMP. Management of pemphigus vulgaris, topical steroids have little effect. So these patients, they have more diffuse disease, and it's systemic steroids that are most preferred. And when you put patients on systemic steroids, you always got to keep in mind that you could be inducing Cushing's syndrome in them. And so you have to have a monitoring protocol on patients with systemic steroids and look at all the signs and symptoms of Cushing's syndrome with increase in body weight or osteoporosis or diabetogenic alteration of their profile, and so on and so forth. So management of lichen planus pemphigoides is fairly simple. If there is ocular disease, of course, it will be managed by the eye specialist. Otherwise, topical and systemic steroids with or without immunomodulators. This is a very mild bullous condition, and it resolves with treatment with very few relapses. So that's a good thing. So we quickly look through some therapeutic agents over here now. Topical steroids are available in the form of solutions and rinses. So in some conditions, our patients may be asked to swish these solutions or rinses in their mouth and spit out. And so that would be more as a topical application. And something for a systemic use, they can swish in their mouth and swallow. So it gets also absorbed by the body. So that's going to be for systemic conditions as in pemphigus. Topical steroids are also available as ointments, creams, gels. Gels tend to work the best in the mouth. And of course, even gels don't stay that well in the oral cavity because of constant secretion of saliva. But of all three, that's the ointment, creams, and gels tend to work the best in the mouth. And so swish and swallow, when do you use that? So typically when you need to give patients systemic steroids, but because they have these painful lesions of their soft palate, their oropharynx, they are not able to swallow something that's hard and firm. So in that situation, you can give them swish and swallow rinses. And so some common formulations are dexamethasone and prednisolone. And typically the dosage is going to be anywhere from 1 to 2 teaspoons 3 times a day. And we'll talk about that soon. So topical steroids that are applied on the mucous membrane, they are classified based on their degree of vasoconstriction that they produce in the region where they're applied as class 1, class 2, class 3, and class 4, with class 1 being most potent. And so in treatment of mucous membrane pemphigoid and erosive lichen planus and CUS and lichen planus pemphigoides, my recommendation would be to go with the most potent topical steroid. And so we're talking about something like betamethasone 0.05% or clobetasol propionate 0.05% gel, or even halobetasol propionate 0.05% gel. So these are super potent or class 1 topical steroids. Class 2 are potent and fluosinonide 0.05%. And so, these are all available in tubes that are typically, even the gel formulations are for mainly skin use for dermatological lesions. And so if you look at all these dispensations, it's clearly put not for ophthalmic use or not for oral consumption, not for ophthalmic use. And so this is what we call as an off-label use. When we use it in the mouth, it's been done for many, many years and it's accepted. And so class 3 are high mid-potency, that's fluocinolone or triamcinolone creams and ointments. And the ADA has now got one which can be used for the oral cavity specifically. That's triamcinolone acetonide, what we call as Kenalog in Orabase, which is for oral use. But it's a somewhat weak steroid. I would definitely prefer a class 1 super potent steroid in the initiation of treatment of these mucocutaneous conditions. And of course, I would not recommend a class 4 low mid potency topical steroid at all, although it's good for the lips because it doesn't produce that much scarring. So swish and swallow prescription. So here's how you dispense: dexamethasone solution, 0.5 milligrams per 5 ml, or if you prefer, prednisolone, 15 milligrams per 5 ml. Dispense 450 or 600 ml. Swish 1 teaspoonful. That's about, I would say, 5 ml. 1 teaspoonful for 5 minutes and swallow 3 times a day. No food or drink for 20 minutes after each use. And I believe this presentation is being recorded, so I'm sure your leaders will share this with you, and so you would avail these prescriptions. Topical corticosteroid prescriptions, clobetasol or class 2 fluocinolone, 0.05% gel. It comes in 15, 30, 45, and 60 gram tubes. Might be different over there. Dry the area. So, it's very important that the gel formulation stays over the lesions for a while. So if you're going to have saliva, it's just going to wash out right away. So it's important to dab the lesions very gently, dry the moisture, and use a cotton tip applicator. Very important. Your patients should be instructed to use a cotton tip applicator, because if they're going to put these steroids on their fingertips and massage their gums with it, because of vasoconstrictive effects of these high potency steroids, they can get scars on their fingers, and you don't want that to happen. So please instruct them to use small quantities applied using a cotton tip applicator only over the lesions. It's like money down the drain if they're going to just swab the whole gingiva, including areas that are not affected by the lesion. It's absolute waste. So small quantities, multiple times a day, right over the lesions themselves using a cotton tip applicator. And once again, no food or drinks for 20 minutes. And patients should be informed that this is an off-label use, and they should also be informed that when you use high potency steroids, it suppresses normal host flora, suppresses inflammation, and there's a possibility of opportunistic pathogens like Candida. So here's a treatment protocol for moderate disease. So I divide that into 3 steps: induction of treatment for 3 to 4 weeks, then maintenance once you have the disease under control, and then follow-up. So induction is always using a class 1 steroid. You really want to hit hard, like clobetasol or halobetasol. And then you could also otherwise go with a class 2 steroid with a steroid rinse, as in dexamethasone, swish and spit. So it's one or the other. And then after 3 to 4 weeks, when you have the lesions under control, you maintenance. So you maintain on class 2 steroid or with the steroid rinse, or you switch to a non-steroidal agent entirely. And my favorite is calcinuric inhibitor, tacrolimus. And so again, you reevaluate your patients after a few weeks and check the stability of the disease. Have you brought it under control? Are your lab tests all normal? Your CBCs are normal? And at that time, you can plan on continuation or reduction of therapy. In patients with more severe disease, you just push things up a notch. So class 1 steroid like clobetasol or halobetasol with the steroid rinse, swish and spit, or dexamethasone, or you go to systemic steroids. You're talking about increased severity of the disease. Systemic steroid with a non-steroid agent, typically something like tacrolimus. And then again, that's for 3 to 4 weeks. Then you go to maintenance state when you've got your disease under control with either a class 1 or class 2 steroid like fluocinamide with swish and spit, or you can discontinue steroids altogether and then go with only steroid sparing agents like tacrolimus. So again, after a few weeks, the follow-up, check the disease status, lab tests, typically CBCs, and then you plan on whether you want to continue your treatment or there's going to be reduction in the dosage of the drugs that you're giving your patients. So these are pictures from Dr. Sukwu at Harvard. And so these are some trays that have been fabricated in patients with erosive lichen planus. It typically affects the attached gingiva. So you fabricate these trays to go all the way up to the, mucogingival junction, and you put the gel formulation inside these trays and ask the patient to wear these trays. And here are pre-treatment and post-treatment photographs from Dr. Wu using these trays. And so in patients that have lesions in their vestibule or on their labial mucosa, you can even soak these pieces of gauze in these medications and tuck these pieces of gauze in the vestibule. And so it maintains the drug in contact with the lesions for a longer period of time. So very quickly, a few words on non-steroidal immunomodulators. Before you start treating your patients with any of these medications, it's very, very important. See, these are very toxic medications, except for tacrolimus, but that is one word of caution I will talk about when I get there. So these toxic medications would always require pre-treatment blood workup to make sure there's no bone marrow suppression, and would require regular monitoring of blood counts and liver function tests, and they're best used under the guidance of a physician or a rheumatologist. And dosages and routes of administration to be studied carefully prior to treatment, and you may require adjustment of the doses based on how the patient responds to the treatment. So very quickly, dapsone is, it's a medication used for the treatment of leprosy. It's also used in the treatment of pneumocystis carinii pneumonia in patients with AIDS. It's also used for treatment of parasitic diseases like toxoplasmosis, but it's found good use in management of mucous membrane pemphigoid. And the way dapsone works is, once again, we are going back to basic pathology. Neutrophils are primary responders in acute inflammation, and they have a lot of neutrally staining granules in them. And so they phagocytose bacteria. So the bacteria are inside a phagosome. And then there are lysosomes and peroxisomes that fuse with the phagosome. And so when a lysosome fuses with the phagosome, lysosomal enzymes digest the bacteria. When a peroxisome fuses with a phagosome, there's a lot of nascent oxygen as well as reactive oxygen species that lyse the bacteria. So we have an oxidative burst mechanism to kill the bacteria, and we have a non-oxidative burst just using chemicals like lysozyme to kill the bacteria. So these are two different mechanisms in which macrophages and neutrophils destroy bacteria in their phagosomes. So dapsone interferes with myeloperoxidase. Myeloperoxidase, the oxidative burst results in an end product known as hypochlorous acid. It's a very potent superoxide. It's very harmful to the body. We produce superoxides in every inflammatory process, but thankfully we got neutralizing agents, what we call as antioxidants. And so the superoxides are typically present for just fractions of a second before they are neutralized by these antioxidants. So what dapsone does is it prevents the degradation of myeloperoxidase into hypochlorous acid. So hypochlorous acid can cause significant tissue damage during inflammation, and when dapsone arrests myeloperoxidase, production of hypochlorous acid is reduced, and therefore it reduces tissue damage. So that's a mechanism of using dapsone in the management of mucous membrane pemphigoid. The cautionary aspect of using dapsone long term is it produces hemolytic anemias. This happens very quickly, especially in those patients who have a deficiency of glucose 6-phosphate dehydrogenase. So here's why it's very, very important to check your G6PD levels in your patients before you stop them on treatment with dapsone. So dapsone is used in several strengths, progressively increasing from 25 milligrams a day all the way to 50 milligrams to 300 milligrams total per day. Once again, word of caution, before you put your patient on dapsone, please check their blood levels of G6PD. You don't want acute hemolytic anemias in your patients. Last few slides, azathioprine. It's an anti-metabolite. It works via a disruption in 6-thioguanine. You know that there are purines and pyrimidines in DNA and RNA. The purines are guanine and I believe it's adenine. And so when there's disruption to guanine, production of DNA and RNA by cells is depleted. So when we talk about this, we are talking about labile cells or primary cells that are constantly dividing. And so the most important cells are those of the epithelium, hair follicles, any epithelially derived structures, and most critically, the bone marrow. So azathioprine is a very toxic substance. It affects the bone marrow directly. And so it also is very toxic to the fetus, in which almost all cells are dividing rapidly, produces birth defects. And so it's very important to monitor your patients using TPMT levels for bone marrow suppression when you're treating them for any oral mucocutaneous autoimmune disease. Mycophenolate mofetil is, again, a very interesting drug. It inhibits purine biosynthesis. That's, again, we're talking about one of the base pairs in DNA synthesis. And so it impacts production and proliferation of T cells and dendritic cells. And that's the mechanism by which we treat lichen planus using mycophenolate mofetil. But once again, since it interferes with synthesis of DNA and RNA, it produces significant myelosuppression and fetal toxicity and birth defects. It's important to use TPMT levels to monitor myelosuppression. Frequent complete blood counts are important in treating patients using this drug. My favorite is going to be, among the immunomodulators, this calcineurin inhibitor known as tacrolimus. I've used tacrolimus in many resistant cases of mucous membrane pemphigoid, as well as erosive lichen planus, with great success. It's not my first line, but it would definitely qualify as my second line. And it's safe in the sense that there is no myelosuppression. Its mechanism is by reducing interleukins and by also reducing expression of interleukin receptors. So it just works entirely on the inflammatory process and reduces T cell activation. There's no deleterious effects on the bone marrow or cellular proliferation of primary or labile cells. And it's 10 to 100 times more potent than cyclosporin in its immunosuppressive effects. And very importantly, unlike mycophenol mofetil or azathioprine, which are meant to be given as intravenous, some calcineurin inhibitors or as tablets, Protopic or tacrolimus is available as a very convenient topical gel formulation. And so 0.1% of the strength of the gel, you dispense 30 grams, apply thin film lesion 3 times a day. Just the word of caution, there have been reports. This is more when tacrolimus is given as an oral medication for systemic use, that it does produce immunosuppression. And in a very small proportion of cases, this immunosuppression has led to development of lymphoma and certain other malignancies. But the benefits of using it far outweigh the risk that in bold and red over here at the bottom of the screen. Your patient, however, needs to be informed about this risk, but I find this medication very useful in my armamentarium of treating mucous membrane pemphigoid and erosive lichen planus. Last few slides. There are other targeted therapies. My favorite over here is going to be, again, CD20 antigen. That's rituximab. There are others against TNF-alpha, against vascular endothelial growth factor, against the TNF-alpha receptors, against tyrosine kinase inhibitors at the level of the nucleus itself, especially imatinib, another wonder drug. Let's quickly look at rituximab. It's a monoclonal antibody against CD20. You know, CD20 is expressed by B cells. It's one of the most crucial markers for B cells. And so it's used in the treatment of lymphomas, chronic lymphocytic leukemia, chronic graft versus host disease, polyangiitis with granulomatosis, which is the new name for Wegener's. And it's also used in the treatment of autoimmune disease such as rheumatoid arthritis, pemphigus vulgaris, and Sjogren's syndrome. Rituximab, however, is given as an IV infusion only. So coming to the last slide in my presentation, kind of putting everything into perspective over here, autoimmune mucocutaneous conditions are many, and they look like each other. Contact hypersensitivity and medications can also cause lesions resembling many of these overlapping mucocutaneous autoimmune conditions. There's overlap in clinical, histopathological findings. Sometimes immunofluorescence permits us to differentiate one from the other. Very, very important, as I highlighted in this presentation, is that clinical correlation should be done to rule out one from the other. And it's important for your patients to realize that autoimmune mucocutaneous diseases can only be managed but cannot be cured. So we can only reduce the signs and symptoms so patients can lead a more productive life. So this patient understanding and compliance is an absolute must